host, Dr. Mike Matthews.
Hey everybody, welcome to the podcast. This is episode 21, and today we are going to go over the normal framework of each episode. We typically start each episode with a case. It's typically the last patient I treated prior to the recording of this episode, and then we'll jump into some questions from the audience and then finish with a general recap and overview. So let's jump right into our case. Today we'll be discussing a case of an 18-year-old male collegiate baseball player, and he originally came to me having already seen multiple other clinicians and continuing to have shoulder pain with throwing, limiting him to the point where he couldn't pitch anymore. He was predominantly a pitcher but does play other positions, but he was unable to really throw, unable to pitch because of this pain. And he came to me having already done what would be considered maybe the traditional rehab approaches, doing a lot of exercises for the shoulder, working on some core strength and posture and those type of things. And he just had not been able to return to the same level as he was previously without some returning of his pain. And so he came and saw me, and we did an initial evaluation. Immediately noticed that he has substantial range of motion in his throwing side, which is great news. But what I also noticed during that initial examination is that he had a hard time controlling all of his range of motion, meaning we had him lay down on his stomach and attempt to bring his throwing arm into full external rotation actively. So the way it looks is they're laying on their stomach with their hand underneath their forehead and the other arm's up at 90 degrees, and then they're asked to lift their hand off the table while keeping their elbow in contact with the table. And what we want to see is a certain degree of range of motion that the player is able to achieve relative to the passive range of motion that was just measured during his examination. And in his case, he really struggled with gaining hardly any external rotation into layback positions. And so that was a major problem we noticed right off the bat. He had great rotator cuff strength, to be honest, except for one position, which we'll talk about in a minute, but he had pretty good rotator cuff strength throughout the shoulder. But the main issue that he noticed was that he just had no ability to control it in external rotation. And so we saw that, and then a couple other things that we saw. He had a little bit of problem with core control, and he couldn't maintain proper position of his shoulder blade on his rib cage. Basically, he just didn't demonstrate what we'd expect to see from a collegiate level pitcher throwing at higher velocity. And so what we did next with him, which is a little bit different than a lot of our athletes, is we actually did a EMG test on one of his rotator cuff muscles. So we actually strength tested all of his rotator cuff using a device that recorded how much force output he had. And what we noticed is that one specific motion, predominantly external rotation, demonstrated substantially low compared to the rest. And so what I wanted to determine was, is he just weak in that area? Does he have an injury to that area? Or is he unable to activate or turn the muscle on that's predominantly responsible for that degree of motion? And we have a device that allows us to test for that. And so we did a neuromuscular deficit test, testing external rotation on both sides and on each shoulder. And what we noticed is that he had a 24% drop of activation potential on his throwing side versus his non-throwing side. And to be honest, one of the things that puzzled me right off the bat was why he was having that. Now, we had the benefit that he actually had an MRI. And so we went and looked at the MRI, and with the help of a physician as well, we started looking around to make sure that there wasn't something going on, maybe like a cyst or something in the shoulder. It was basically not allowing a specific nerve that helps with this muscle, that it wasn't being impinged or something along those lines. It didn't allow it to fire correctly. And what we noticed is that actually everything was fine in the MRI. He just has this large neuromuscular deficit. Now, without anything on the MRI and without anything really indicating the reason why he should be having this, we went ahead and just said, you know what, let's train it and see if we can improve it. And so what we've been doing is using that same EMG device that we used to test, we used to basically teach him to fire that muscle better. And we haven't retested him yet. He's been in a couple visits, but we've been training him pretty heavily on that now. What we've already noticed is his active range of motion into external rotation, laying down up at 90 degrees, is already substantially better. He's developed the ability to know how to control his shoulder in that position. We did strength test external rotation again, and he definitely demonstrated an improvement already. So I'm thinking what happened is that this is a guy that had gone through substantial amounts of rehab before. I mean, he'd been through 4 to 6 to 8 weeks of rehabilitation, predominantly targeting and strengthening his shoulders. And what had happened is that he was just compensated through those other exercises, and it was difficult to see, and unless it was specifically tested for, I don't think we would have caught it either. And so the hope here is that this is a guy that can throw pretty hard. He's a low to mid 90s pitcher, and so the idea is that we hope that and another key point of this is that he actually had no pain at all in his shoulder if he was throwing in the high 80s. And so when he was at submaximal levels, he was still able to pitch and be effective. The problem was he definitely wasn't optimal. And it wasn't until he started trying to throw at these higher velocities that he started noticing this type of pain. And so we're hoping that the addressing the neuromuscular deficit in the shoulder, as well as targeting and specifically tracking these variables in his shoulder, is going to translate to important improvements with his ability to be able to pitch without any pain. And currently he's on a throwing program right now. He's been throwing for the majority of this, but right now he's only at 105 feet, and it's only about 50 throws total. And as of right now, he doesn't have any pain, but I don't expect him to have any pain at this distance. It's more maybe when you get the 120, 150, and when he starts pulling down a little bit to try and gain velocity. We're in the time of season that he doesn't need to, and so we're on a pretty conservative throwing progression. And I don't know if we'll cut him loose and let him really go until he shows us on that neuromuscular deficit test that he's pretty much gotten rid of it. And if we can't improve that, maybe that neuromuscular deficit never goes away, then that's something that's going to need further investigation to make sure there's not something going on with that muscle itself, or that the tendon doesn't have a problem. His pain is definitely in the shoulder, and so it could be a tendon problem, but realistically what didn't test as a tendon problem. Everything kind of tested. It wasn't painful. It just tested as weak, and then the EMG data definitely pointed us in the direction that he just wasn't able to activate and to create enough potential or contraction quality in that muscle to be able to control his shoulder when he was throwing. And so hopefully that it improves. Hopefully we were able to get him back pitching 100% without any difficulty or problems. And so there was one other thing in regards to him as well. We tested for anterior core strength and endurance, basically just making sure that he can maintain a certain position when trying to generate force through the core or obliques. And what we noticed is that he had a hard time controlling his pelvis. He typically, anytime he tried to load, his pelvis would move rather than staying stable. And the way it looks like is that our players have to be in a tall kneeling position. That's both knees on the ground. They're up as tall as they can get. So it's basically a straight line between their knees up to their shoulders. And we ensure this by placing a PVC pipe along the back side of them so that they're basically their butt cheek, their middle of their back, their shoulder blade, and the back side of their head all are in contact with this vertical PVC pipe. And then they have to generate an anterior driven force, which is basically like an ab crunch in front, but they can't move off of the pole. And if they do that, then essentially are disqualified from the test, or we can't take that because they're compensating. Most guys can figure it out. In his case, he actually struggled quite a bit. And so I think that's actually another thing that will improve his ability. We're talking about a guy with, again, he throws pretty hard. He's got substantial range of motion in his shoulder, and he demonstrated poor anterior core control, poor scapular ability to control his scapula during just basic reaches, and then demonstrated a substantial muscle deficit in the rotator cuff. He's essentially a guy that just is too unstable and can't stabilize his shoulder, can't keep the ball in the middle of the socket when he's trying to throw hard. And that's why I believe his pain is being produced. So the hope is, again, we see that neuromuscular deficit go away. He's able to test really well in the anterior core strength and his shoulder blade function. And we should see that correlate to an increase in his ability to be able to pitch at higher velocities. More to come. It's going to be a long process before we actually see him trying to throw that hard. But I think we're on the right path. And I think the cool part about this case, just to illustrate, is sometimes it takes very accurate testing to be able to identify some of these problems. These are elite level athletes. These are collegiate level. In his case, it's he's an elite level pitcher, and unless we had tested specifically and had the ability to make sure that the test was done correctly and accurately, I don't know if we would have caught a few of these things. And so it's nice to have those tools here. It's nice to have that ability to do so. And so I'm hoping we'll see him improve and be able to get back to where he needs to be. So, all right, that does it for our case. So we're going to jump right into our questions. Just a note on the questions here. There's a couple questions. I changed the questions on a few of these because they were fairly specific. And so I tried to answer those questions very specifically back to that person, but then I generalized the question because I felt like they were great questions for the podcast. And so if I fumble around a little bit with what I'm trying to say, it's because I had to change the wording, and sometimes it just doesn't quite sound as good as the original person wrote it. And so let's jump right into our questions. So question 1 comes from Mel. And it said, I am dealing with pain in my thoracic spine. It started with me lifting an object that was quite heavy, but I thought I could do it. And did, and then I paid for it later. The pain is substantial. Would you recommend ice or heat for pain relief, as I've heard a lot of different recommendations? So Mel, in regards to your question, your specific question is ice or heat. My specific answer for you, an acute injury, I don't know where your pain is. You say it's in your thoracic spine, but I'm not sure if that means it's more in the muscle or more in the joint. However, what I would tell you to do is that you try heat first, about 10 to 15 minutes, and then if it doesn't work or you don't feel like heat does the job, then try ice. And then if ice doesn't do the job, then you may have to swap back and forth and you kind of different combinations. But realistically, at this point, we're trying to mitigate pain, and that's a big distinction. So if someone has an injury, say a muscular injury, and their muscle is, we know for sure that they have a muscle strain, and it's not a joint problem, it's not a ligament problem, well, even if it's a ligament problem, even if it's a joint problem actually. But realistically, if we're not just dealing with something that's just really painful, we almost always lead with heat. And to be honest, I think we lead with heat almost everything minus an open wound, which we lead with a lot of other things before we even talk about ice or heat. But in this case, Mel, to answer your question, I would start with heat, see if it works. If it doesn't, try ice, and then combinations after that if that doesn't work. But I can tell you right now, you're specifically talking about pain. I can tell you this, that the only thing that I've seen ice work effectively on is pain. Now, I'll be honest, I've seen heat work just as effectively on these type of things as ice, which is also the reason why I recommend heat first. Because sometimes you have a muscular injury on top of another injury, and you're trying to just decrease pain, but at the same time, ice restricts the ability for the body to bring blood to the area, which is that's the healing process. And so we don't really want to stop that. So if heat does the job taking your pain down, we also get the enhancement of blood flow with that as well. And so that's a little more specific answer to you. Mel, one of the other things I want to talk about with thoracic spine pain, and I think it's something that's commonly missed, and that is that when we talk about these type of pains, it's usually a pain that hurts when you breathe, when you rotate, when you lay down. It's one of the things that I found is a lot of times these patients will lay down and they'll still continue to have pain. Now that's laying on their back or on their stomach. But then actually what ends up being is that laying on a certain side is actually okay. And if we're talking about specific thoracic spine pain, and when we say thoracic spine pain, let me be more specific. We're talking about pain that's coming from the spine itself, not from the muscles, most likely coming from the joints of the thoracic spine. What we have found to be most effective in regards to getting these patients back is a quick start of physical therapy or treatment. Because what we found is we need to decrease or take the pain cycle down or interrupt the pain cycle that's going on. It's a postural based part of the spine. I mean, the whole spine's postural based, but it's heavily weighted by gravity. Our shoulder blades move upon the rib cage, which is attached to the thoracic spine. So almost every motion is going to cause some degree of pain. And the idea here is we have to desensitize the spine by decreasing the activities that cause pain. So the protocol looks like this. It's a lot of, I kind of laid it out, but realistically, let me make it very simple. you need the pain to go down. And so what you have to do is that you need to take time off. You need to rest. You need to lay down specifically on a side that doesn't have pain. It only has to be about 20 to 30 minutes. Then you can get back up. When you get back up, you can get up and stay up as long as that pain doesn't increase to the point where it's substantial again, because then you're going to need to lay back down. Now, medications, everything else like that is a good idea. While you're laying down, that's when you can use your heat or your ice, your electrical stimulation if you have it. That can also be effective. But the key here is breaking the pain cycle, and where I think people go wrong with thoracic spine pain a lot of times, especially, and we're talking about a pain that's acute, not something that's been chronic and been there for a long period of time. This is that's a totally different treatment. But someone like Mel was describing, I lifted something, I was able to do it, but I noticed it was too much, but then later, oh my gosh, now everything's fired up. If that's the type of pain we're talking about, this is the protocol, and that is you need to get off your feet, lay down where you don't feel pain at all. You then need to transition. Once you're out of pain, you can stay there for about 20-30 minutes, then get back up, go back to normal daily activities as long as the pain doesn't increase. Once it does start to increase again, you need to lay back down and take another 20 to 30 minute break. My patient, similar pain, actually thanked me because she said, I appreciate you allowing me and giving me permission to be lazy. And that's pretty true. Because you have to decrease this pain cycle. And when you do that, this pain will actually go away quite quickly, because what happens is most of the time people don't take the time off. They keep resensitizing the pain that's usually in the joints, and the pain just sticks around and it never goes away. They sleep, they wake up, it's stiff, and it feels a little bit better in the morning, but then they get going again and they never give it a break. And so that pain cycle ramps back up and they stay in pain for longer than they need to. Now, I can tell you this, Mel, I really like seeing these patients immediately. So if someone has the issue, they have the issue, and then they come and they see me within hours, not days, but hours of it happening. And what we're able to do then is really break the pain cycle. So we teach this whole protocol that I just explained right now. And then the other thing that we do is we use dry needling along the spinal areas that are the problem and run electrical current through that as well. That decreases, really bucks the pain cycle, which is what we're trying to do. And what we've noticed is if we're able to get on that really quickly, we're talking getting this pain to go away. And for those that listen more to the podcast, you know that I kind of grade everything in time off of either hours to days, days to weeks, weeks to months, months to years. This is an issue that can go from days to weeks to hours to days. So where we can actually get this thing to go away within like 36 hours and sometimes even shorter if we get to it quick enough and break the pain cycle and stay ahead of it. So in regards to thoracic spine pain that is acute, meaning you know what happened, you know what you did, get it treated quickly and follow that protocol I just discussed, Mel. And I think what you'll find is a substantial decrease in your pain and your improvement in your abilities. I hope that answers your question. I understand that most everybody's busy, everybody's got things to do, and the key is just taking specific strategic time outs, whatever you want to call them, laziness periods, breaks, I don't know, doesn't matter. But the idea is you take those times when you need to, and you play it by the symptoms that you're having, the amount of pain you're having, and you go through that protocol until that pain breaks, and then get treatment as soon as you can. A good physical therapist that can dry needle is really good here. It's been highly effective at getting this type of pain to stop. So, all right, thanks for the question. All right, next question comes from Dan, and Dan says, my son has been through a movement screen that you provided. Thanks, Dan, for letting your son come in for a movement screen, probably on one of our high school teams that we screen. Back story here, we go out to our local high schools and other teams, and we provide a movement screen. It's fairly basic, but it identifies the key areas where we typically see injuries, and it's very geared towards specific age groups. We predominantly targeted high schools because they're a little bit easier to get into, and to be honest, that's where a lot of injuries happen. And we were able to go in and identify range of motion deficits or strength deficits and give these kids a little bit more of a structured program and stay ahead of things and hopefully keep a lot of them out of our facility and on the field, both in the fall and in the spring and any type of season, to be honest. And so anyways, so it sounds like Dan and his son went through this process. So went through a move screen that you provided, and you mentioned that you were working on something to improve muscle quality. Can you explain what you mean by that? Well, Dan, I wish I could. Because when you say working on something to improve muscle quality, I feel like that's something we do every day. But probably a better way to answer your question here, Dan, is kind of like a general, well, what are we doing for muscles? Let's put it this way. Dan, I'm not sure I can answer your question specifically. We have multiple things, projects, whatever you want to call them, going on at a single time while at Athletic Potential. And let me just kind of maybe give you just an overview of what we're working on, and maybe it'll be the one that I was talking about. So apologize, I can't give you a specific answer. Maybe if I don't know. Well, let me just tell you. So right now we're working on measuring force and comparing it to EMG data. And so what we're trying to determine is that those that score fairly low on force testing, and whatever it is we're testing, we want to see and compare it to EMG data. And we compare it side to side. And so the idea would be, okay, this patient demonstrates he's weak. And traditionally in the past, what we would normally do is say, okay, we need to improve his strength, and we'd give him exercises specifically designed to improve strength based on the test. What we found is that it's been effective for the most part, but what we've also found is that there's a subset of our athletes that just don't do well with that. They don't seem to get as better as fast as we'd expect someone to get better, in that they, it just doesn't turn around very well. And so what we're doing now is looking at their ability to actually turn on the muscles. And I mean, it's like our case example today. This is a guy that when we tested him, he tested really weak, but I'll be honest, I think it was him. His initial test actually looked really good, but what we noticed is he was substantially compensating. We didn't notice until we actually stabilized and standardized his position for the test, meaning we had him stand tall, his shoulder blades had to be in the right position, his elbow had to be locked to his side. And then the first test, he didn't do any of that. He basically allowed his shoulder blade to come forward, and he left his arm and was able to generate force. And his test actually was pretty good. And then when we re-looked at it, when we tested with that standardized position, he was weak. And we retested, and he was still weak. And then what we did is, like I said earlier, we added the EMG data and looked for a deficit. And what we found was that there was a deficit. And the reason why we went there is because, one, he told me he'd already gone through all these exercises. And I'm thinking, well, if you're doing all these exercises in a compensating pattern, maybe you just never actually targeted the muscle, or maybe you actually can't target the muscle, and so you've always compensated around it. And what we found in his case is he had a neuromuscular deficit. He could not activate the muscle correctly or well. And so we were targeting his muscle and training a lot differently. And so that's something that we're working a lot on. So we're doing that with baseball players in regards to their muscles in their forearms, specifically the ones that are supposed to protect the UCL. We're putting different devices there to measure EMG and a few other things, and then comparing it with strength measures. And I don't know if I can really give you a whole lot of feedback on how that's going right now. I can tell you that we weren't as shocked. We didn't obviously see a ton of deficit in a lot of our athletes. They seem to be fairly strong and could activate fairly well. I think what we are actually seeing, though, is that when we have our athletes testing and then using the same device to improve contraction quality, I think we're just getting more out of every rep. They're not doing more reps. They're doing the same amount of reps that they were doing before, but now they're getting feedback, so biofeedback, and their contraction quality, their ability to flex the muscle is way better. And I don't know if it's because they have something that's telling them, which is the point of biofeedback, or I don't know, maybe they're just more focused. And so that's something we're working on, and we've seen some really cool stuff with that so far. So I like that. We're looking into a lot of anterior core stability. We're really trying to measure an athlete's ability to maintain pelvic position. We see this in almost all of our youth athletes. This is where they really, really struggle. And what we've noticed is we've taken a few groups, one group specifically. We have one group going right now, but we had another group that we targeted this very specifically with. And I'll be honest, we did not do a traditional strength conditioning program with these guys. We did what we would call motor control in the therapy world. We specifically just taught them to maintain good posture in a whole bunch of movements. And we had guys doing some weird stuff, I'll be honest, but with bands and trying to control things. And we made games out of it because they're younger. And just talking to their coach. So for what it's worth, and the coach is pretty straightforward. He would tell me if they didn't get any better. He's telling me he's seen better movement. They have less errors. Maybe that's just because they're older, but at the same time, they be throwing more consistently. They're making more contact, more like good contact at the plate. And they really haven't changed a ton of their skill work other than they just continue to work at it. But one of the main, I think that he said the main thing that we're looking at is that they're just improving. They're doing a lot of this anterior core. And he just says they have better movers. They just look like they're moving better. And so that's something that's kind of been fun to see. We're working a lot on that. Let's see, what are some of the other projects we've got going on? We're measuring differently now. We're using a lot of different systems. I'll be honest, we're going really digital now. I used to hand to measure everything with a bubble goniometer, which is really good. It's what a lot of the research does. Most of the research is doing. However, we're starting to look at standardizing ways with digital measurements. It's a bunch of nerd talk, to be honest, but it allows us to actually screen more athletes faster and more accurately. And there's some really good stuff with that. I think we're working on our big test with that. It's in another week and a half when we're going to screen a big group and really put this protocol to the test. And so that'd be something to be kind of fun to see. I think we'll be able to build a fairly big database with that. That's predominantly with baseball players. We're doing a softball study as well. We're looking at trying to measure certain forces with throwing with the windmill pitch in softballers. It just seems like the research out there is a little rough, and so I've got a few girls that have signed up. Hopefully we'll get some more, and hopefully be able to put a good little data set together and use some technology to measure some things. So Dan, this is a great question. To be honest, I think about it when I try to tell people what I'm doing every day and those type of things. I said basically what we're trying to do is use the best technology that we can get to improve obviously the abilities of our athletes, and in order to do that we have to test well, we have to train well, and then we have to retest well. And I think if we do that, we're going to see the best results. And so those are some projects we're working on right now at Athletic Potential. To be honest, I just thought of two more, but there's a lot of detail there. So anyways, Dan, I hope that answers your question and trying to improve muscle quality. I probably was talking about EMG. It's something that we've really integrated more lately. And so anyways, great question, Dan. It was kind of fun to talk about and think about all the stuff we've got going on. So, all right, question 3 comes from Jen. Jen says, I have a daughter who is trying to return to full sport participation. She has been cleared by her doctor and physical therapist to return, but hasn't returned to her normal self on the field. What are the key things that you look for in an athlete in their readiness to return to sport? These are great questions. This is a great question. So, I don't want to go through all the testing. So, okay, let's try to answer this question in the sense that the doctor's seen your daughter. Now, I don't have a sport, so I don't know what sport we're talking about. I don't have age. I don't have how long it's been. Could be 2 years. Could be just barely starting. So, let's put it this way. There's always a time frame, and the time frame is completely dependent on the type of surgery, or let's see. It doesn't even say your daughter had surgery. So let's just say there's a time frame on tissue healing, and it all depends on whatever that tissue it is and how the tissue is injured, repaired, reconstructed, whatever. That really determines a lot of when that athlete should return. And so they have to go through all the testing. They have to be cleared. They have to go through training and good strength conditioning and those type of things. And let's just say that all of those things happen because you talked about a doctor and a physical therapist having cleared your daughter to play and return, but you're just not seeing it. I can tell you this, and I don't know if this is your experience or not, but maybe one key I'll discuss, because to be honest, this is a huge topic. I mean, there's entire days and conferences talking about just ACL return protocols and how and what they should look like and different opinions, and there's a lot of good stuff out there, and there's some things that should be done. And I'm not saying, Jen, I don't know if your daughter had an ACL reconstruction or anything like that, but the idea is there's a lot of things here. But I think one of the key things that we've noticed in our athletes here, in getting our athletes back to the field and back to the field normal, you're talking about her normal self, is this. And I don't think this happens nearly often enough, and it's something that we've really worked hard at Athletic Potential to make sure it happens. We obviously have a facility that has turf and cages and ability to run and hit and jump and cut and do all those type of things, which is great. So that's one thing. So if your daughter was in the doctor's offices in the physical therapy environment, and that physical therapy environment is I don't even know if I know what a traditional therapy environment looks like now, but the idea is, essentially a room that's carpeted with a lot of tables, a lot of equipment, not a lot of open space, a lot of different types of people working on very specific exercises, with some hands-on techniques from the therapists and those type of things. But it's not a sport atmosphere. It's not a strength conditioning environment. It's not a training, like sport training facility. And if your daughter didn't get and basically went from physical therapy and was graduated from there and then was like, all right, hey, go for it, there's a huge gap, a massive gap at getting back to sport, because they haven't even, at that point, your daughter may not even step back on the field or the court or whatever. And so one of the things that we've been really working on athletic potential with this is that we try to get our athletes to quite literally never leave their particular field or sport ever. And so even if they had surgery, so case in point, we just had one of our athletes just go through an ACL reconstruction. I specifically told her, look, you're going to be braced up, bandaged up, keep your pain levels low. I gave her all the guidelines, and I said, but if you're feeling good, I need you back out at practice, at least watching, or at least in some part, I need you in the sport. I need you there watching. I need you watching it. I need you participating in whatever, watching film, doing something in regards to your sport that keeps you engaged in it. And I don't want you to be gone from your team for months at a time in regards to this rehab process. Get back with them, be around them. I don't want you to lose that. And the reason is because once they lose that, they have to kind of integrate back in. And that can be a hard thing because there's no shared memories with the other athletes. There's no, it can be a tough thing. And then the other thing is that if they've been gone that long from the field of play, sometimes that field of play where they probably were injured is kind of scary. It's an environment that the last time that they were there, things didn't go very well, and we don't want that to be the last experience. And so, I'll be honest, it's one of the biggest things we've seen in getting our athletes back. And sometimes we get athletes that have been other places and other rehab realms, and they come to us because, again, same thing, Jen. They just aren't their normal self, and we look at them, we test them, and I'm like, my gosh, everything looks good. Like your rehab specialist did a great job. We see things here and there that we can improve upon, but then realistically, this happened twice to me last week. I asked the athlete, same concepts of everything looks pretty good, and so tell me what's the biggest holdup, and they couldn't give me a good answer. And in one of the cases, we actually went to the athlete's facility and where they train with their team, and I watched them there, and I talked to their coaches, and you could just tell they just hadn't been there, and so they just need to spend time there. And the good news is the more time they spend there and the more confidence they can build knowing that they're healthy and ready to go and doing the skills and back into their sport as normal, I think that we see a major return and better return from those athletes. And so we see it in a ton of our baseball softballers. I always caution them when they go out and do their throwing programs with their teams because they want to show off, and I just tell them, I can't do that, but I need you out there, but I can't have you throw when they're throwing, And so the idea is they go out and they do their best. But I really like a key aspect for us, and maybe this is commonplace, but maybe I don't know if it is because I don't see it in our location, and I've definitely seen some problems with it, and that is we need the athletes to be in their sport. If they're going to return and want to play, and we're assuming that's the case, Jen, with your daughter, is that she's trying to return, she needs to be in her sport, and maybe that she wasn't. Maybe she was, and she's just not quite her normal self. If that's the case, Jen, reach out to me. Just shoot me an email or something, or call our number here, and let's talk about it and see if we can help you solve it. But realistically, we're talking about a key. You asked about what are some of the keys or some things that we look for in our athletes. I think outside of the normal things you'd expect, strength, conditioning, range of motion, progression back, all those testing, passing all of those tests. Outside of that, I want them in their sport, and I want them back in and around their sport as soon as possible, if never left it in the first place. And so, I don't know. I hope that helps, Jen, and maybe that'll help you, give you some insight of what's going on and some things you can do to help your daughter return a little bit. But yeah. yeah, I think that's definitely one of the things we see. So I hope that answers your question. So. All right, that's all the questions for today on this episode 21. So episode 21, we talked about rotator cuff injury and a collegiate baseball pitcher, and we noticed that he had, in order to actually discover what was going on with him, we had to test him very intricately, and we had to find deficits, and we did so. And again, that never would happen unless we could test him fairly well and be very specific and detail-oriented and thorough with that examination. So that was good to see, and hopefully we'll be able to see him return. We talked about protocols for after thoracic spine pain. It's all about just getting rid of that pain and decreasing the pain cycle, and making sure you take your lazy times or whatever you want to call them. Make sure you take those times off. Give yourself a break when you need it to break the pain cycle, and then highly recommend getting in treatment as soon as you can with those. Particularly if someone who can dry needle, that seems to be the best. We talked a lot about our projects here at Athletic Potential, just a lot of stuff going on, always trying to improve the way we help our athletes and get our athletes back on the field a little bit faster and or better or at higher qualities, and obviously hopefully help them progress to the next level if that's their goal. And then we talked about keys to returning, or a key to returning to sport, and that if you want to be back in your sport, I highly recommend you never leave the sport even after an injury. Try to reorient and give yourself a chance to get back. Always looking at it as an opportunity. It's a terrible event, I feel for every athlete that gets hurt. I got hurt as an athlete multiple times, and one of which ended my career as a baseball player. So, but I can tell you this, that the athletes that can view their injury as almost a gift, they seem to do very well, and they look at it as an opportunity to get better and to come back as a better athlete than they were before. And so I appreciate everybody listening to the episode and listen to the podcast. If you do have questions, again, visit our website, click the button, ask your questions. We want to make sure we answer all of those questions. It's fun to answer them. It gives us a chance to see our methods and how we do things and review them ourselves here at Athletic Potential, but also to try and maybe give some insight to everybody out there and things that they can do to help improve their ability to achieve your athletic potential. And that does it for this episode, and we'll catch you next time.